Good afternoon and welcome to our second week of class. We are this week going to be discussing the supply side. First class, we did a long overview on the demand side after we gave some high level instructions and talking points about the economy as a whole. Then we dove into the health economy. We talked about issues in the healthcare industry that leads to high costs. And then we talked about demand and supply curves and focused a lot on the demand side for healthcare from the consumer perspective. This week, we get into the perspective of the provider, and that's specifically the physician, not hospitals yet, just the physician. So before we start, I thought I would do an overview of the RAND study, which was your case study. And the reason why I assigned the RAND study this week was because that is an experiment that was done in the US that proves that the demand curve is downward sloping. And it's a big deal that the demand curve is downward sloping because that basically becomes an economic law. And so I wanted you to see in practice that the demand curve is downward sloping, which basically means as costs goes down, the demand for healthcare services goes up, and that creates a downward sloping line. And that's a tenet of the healthcare economy. That's a tenet of economics in general. And the RAND study, as you read through it, proves it. And so there's 5 key takeaways from the RAND study that I want to talk about. The first one is it was an experiment. So it's very hard to prove economic principles in practice. And the fact that the RAND study existed and it was randomized, which means that we randomly assigned these healthcare plans to people. It wasn't like we said sick people needed best health insurance, healthy people need the high deductible health insurance. We actually got to see what happens to consumer demand when we applied this randomized experiment. So the key to RAND is that it's randomized. It's important to know. That's the first thing. And it's rare to find true experiments. So we talked about healthcare economics. A lot of times we talk about things that remain constant. So we say in a perfect world, this is how things would work. It was an amazing opportunity to see healthcare in the true form on an experimental basis with RAND, which hasn't been done before. So it's something that all health economists go back to show what happens in healthcare with demand and with price. And it can help shape your ideas for when you have to do your paper on Medicare for All. So the first key for the RAND study was that it was randomized and it showed how demand changes when it comes to price. And in this instance, price wasn't just the premium people paid for the health insurance, but it was also how much money they have to pay out of pocket. And that's the key thing about insurance, because in the first class, we talked about how insurance can actually change behavior because it lowers the cost of care to people. And so you see in this experiment that as the cost to person out-of-pocket expenses went lower, the demand that they wanted went up higher. Now let's measure it. So I'm showing an exhibit. This is straight from the RAND case study, and you can see coinsurance. So the coinsurance basically means I'm going to co-pay with my health plan. So in a 95% coinsurance plan, the last one, I am paying 95% of the cost. So if I went to the doctor and the doctor's visit costs $100, I would have to pay $95 to the provider, and $5 would come from Empire Blue Cross Blue Shield. In the first one, the one that's called free care, coinsurance is zero, which means the health plan pays everything. And it's not like you have a deductible up front. They pay everything first dollar coverage. And so you can see the visits. The visits dropped precipitously, almost in half, when you move from free care to a high deductible plan. They went from 4.5 visits all the way down to 2.73 visits as the deductible went higher. So this is proven fact that demand is downward sloping. As the price went higher, people got less visits. Now, what if they were sick in a high deductible plan? Did it mean that they didn't go to the doctor because the price was too high? That in lies the issue, and that's what health economics tries to treat. And then the reverse can happen. What if healthcare was free, but they weren't sick? Would they go for frivolous issues like, oh, I have a blackhead, let me go to my dermatologist because it's a free visit, so I don't care anyway? So that's another key issue that we think about. Now, there is time and salary that's impacted by going to get free healthcare. So like you have to take time from work and things like that. But the actual outpay, the dollar that they pay out of pocket is much less. And so that just lets you believe that when the price is lower, more people will get healthcare, right? So the second thing that we want to talk about for this study, the second premise was the change in visits. And this would show elasticity. We talked about this last week. Elasticity is the measure of the change. It tries to measure, well, how much visits would decrease when the price goes up, right? And this, using these numbers, we could back into a formula to say the change in price over the change in quantity. As the price goes up and the person pays more out of pocket, quantity goes down. And we could back into an actual number to say every time I increase price by $1, visit limits goes down by X. And there's actually formulas in the book that we talk about that discuss that. So it's very important. Now, this is an elastic demand, right? Because price visits went down from 4.5 all the way down to 2.73. But let's look at admission rates. Admission rates are admissions into the hospital. Now, this is much harder to do if you're not sick, because the hospital won't admit you. They would only admit you through a pre-authorization or through ensuring that you're actually sick. So there's a much tighter band in the number of visits, right? So you can see the visit rates, 4.5 to 2.73, but look at the admission rates. It's a much tighter band. 0.12 for free care. So when things were absolutely free, and you know inpatient visits are very expensive, there was 0.128 admission rates. Not a lot, right? And when healthcare was 95% out of pocket for the person, meaning I have to pay 95% of that bill, an inpatient visit can be $5,000, $10,000, and I would be on the hook for 95% of that bill. It only dropped to 0.09 for admission rates as a percentage. That's a big deal, that it went from 13%, 0.128, only down to 10%, 0.9. That's a very small band. So that's something we would call inelastic. It's inelastic because even though the costs went up high, you didn't see the demand change a lot. That's a big deal. And then the last column shows spending. Obviously, free care, people spent a lot, $1,300. This is 2003 versus when they were paying a 95% coinsurance out of pocket, it dropped to $946. So if you were a Republican, what would you take away from this study? This is the third tenet, politics. If you're a Republican, what would you take away from this study? We know from the reading that technically, after the study was over, we didn't see change in health outcomes. The people who had the free care and the people who had the high deductible care, we didn't see a change in their health, right? So if I was a Republican, I would say, why would I give people Medicare for all and it's free if it doesn't actually change their health outcome? That would be one place. Now, if I'm a Democrat on the other side who's pushing for Medicare for all, if I'm Bernie Sanders, I would say, whoa, wait a second. We saw in the literature, low-income people, poor people actually did not go to the doctor when they had a high deductible. So they actually became sicker, and they had a 10% increase in death rates because of how much money they had to pay out of pocket for healthcare. Faster to bankruptcy, and it's a big issue. So if I'm a Democrat, I would say it's okay because the extra money in spending offsets the 10% higher death rate, right? They would say it's a means to an end. And so this is the debate. The debate is, do I give people free care and have to deal with extra spending, $1,300 versus $946, or do I say I want a free market and let people buy what they can buy no matter what? And if they want to buy a high deductible plan that's very cheap because they think they're healthy, cool, let them buy it. I'm a capitalist. If they want to buy a free healthcare plan that's more expensive, that covers everything, let them buy it. And then the sick people will buy the free care, the healthy people will buy the high deductible plan, and everything's golden. And that's the state we're in today. That's exactly what the market's happening now. And later on in our course, we're going to talk about how it's so hard to predict our risk. So even in a perfect market, and that gets back to uncertainty, which was something we also talked about last week. But because healthcare is so different than any other market, you don't know when you're going to get sick, and you can't prevent yourself from getting sick. So your ability to predict how healthy you are going to be when you are purchasing a plan is nearly impossible. Think about it, right? Most of you guys, if you work for an employer, you're choosing your benefits around October and November, you're making a decision for the whole entire year. You can't change what plan you're in unless you have a qualifying event. That's if you get married, you change jobs, you have a baby, etc., right? So you're making that annual decision one time in September or October or November. And then that decision, say you feel healthy, will carry you out for the next 12 months. So say you feel healthy, you get the high deductible plan, but then you end up, unfortunately, with a catastrophic disease. You find out you have cancer. You have to pay 95% out of your pocket. So that just shows you the issues that we have with predicting our risk. And we're going to talk about that. That's in a later chapter called adverse selection. On the flip side, maybe you don't have risk tolerance. You are around risk avoidance. So you're saying, I'm going to be healthy. But even though I'm going to be healthy, I don't want to take a chance. So you buy the free care plan, you spend a lot of money, then you go through the whole year, and then you get to December and say, I spent so much money out of my pocket, and I never used this healthcare. On that end, you would have lower utility. We talked about utility last week. From your health plan, you wouldn't feel like you got enough from it, so you'd be disgruntled. And so some of our satisfaction rating about our healthcare plans, a lot of it has to do with whether we used it or whether we use it or lose it or whether we didn't use it. It has nothing to do with how good the plan was. It was if people felt that an economic benefit from it. And the reason that is because we're all trying to seek equilibrium. Remember we talked about equilibrium? And that's where we are demanding the same amount the supplier is supplying. Equilibrium would be the plan that I picked was exactly for me. I got the same exact visits that I wanted at the same exact price that I wanted. Very hard to do that at a macro level. Very hard to do that. So those were the key takeaways. Number 4, no effect on healthcare status. That's important. Why did that happen? I would argue that you can't tell health status within a year, 2 years, 3 years. You really have to do a long-term view. Think about this first row. $0 co-insurance free health care. They had way more visits than everybody else. So you would hope that they're finding preventive care. They're finding preventative issues. They're learning about their high cholesterol, their blood pressure, things like that. So you hope that they're treating things earlier on than later on, where that's not happening in a 95% co-insurance folks. They're reluctant to go to the doctor. So they will only go when they get sick, right? And by that time, it's too late. So you're treating something at a more expensive level. So that's one piece. But think about that extra money, that $1,300. There's about a $400 spread between the lowest price amount per year versus the highest price amount. You would hope that all that extra testing and all those extra dollars spent for the free healthcare people will save you in the long run because you discovered something earlier on and you could intervene. However, that means you would have to look at a person 20 years later to see, on average, did you save something? Did you catch something early? So one of the reasons why we saw that there was no effects on healthcare spending was maybe we just looked at a lens that was too short, not just 5 years, 4 years, 3 years. We have to look way longer term, right? The other thing there is poor and the sick. I mentioned this before. That's number 4. The poor and the sick folks, if they were in the wrong plan, they couldn't afford to pay money out of pocket, so they foregone health care. That's the worst thing you ever want to have happen. Someone who's sick that doesn't go to the doctor because they can't pay out of pocket. Because what ends up happening is they end up in the emergency room and we all pay. And so part of the Medicare for All plan is trying to get those folks into the doctor earlier on so we could do preventive care. It is crazy in America that the likelihood to die from either being underinsured or uninsured goes up by 10% based on this experiment. We have to make sure that we cover all Americans, or if we're not going to cover all Americans have access to affordable healthcare that they can buy, right? And then number 5, the last piece, they talked about high deductible health plans. I'm sure many of you have what we call high deductible health plans, consumer-directed health plans. These are deductibles that are $2,000, $2,500, $3,000, and you have to pay that amount of money before the health plan kicks in. Now, how is that plan constructed based on the RAND study? So this is empirical evidence of us using health economics to create health insurance products. So we saw if I give someone a high deductible, they don't see the doctor. But I also want people to get preventive care and not to forego preventive care right? Because their price is too high. So we created a high deductible health plan that gives preventive care free. So most high deductible health plans, for you to be able to put money into your HSA or HRA, they have to cover preventive care free. That's your mammograms, that's your annual physicals, that's your pap smears, that's your well child visits, that's your immunizations. All that is covered in full when you have a high deductible health plan, a qualified high deductible health plan under the IRS guidelines. The reason why we did that is because we saw how much the visit limits decreased with the high deductible plan. So we said, okay, let's make the free care, we're going to combine the high deductible plan and the free care plan, but the free care plan will just be for preventive visits, and the high deductible plan will be for regular healthcare visits. They mushed the two together and created the high deductible plan. Here was the other thing. If you're in a high deductible plan, how are you going to fund the money if you don't have money on January 1st? So many of you may have a high deductible health plan. On January 1st, your deductible is $2,000. You're like, I don't have $2,000. How do I do it? So they added to it a health savings account. And the intent of that was it's a 401k for healthcare. So as you get money from your job on a pre-tax basis, you can put money into a health savings account specifically for medical expenses. And that helps you get to the $2,000 faster because it's tax-free. So you're getting a tax haven. So you're upwards of saving of 28%, 30% in taxes, putting money into an account like a 401k, but it's just for your healthcare. That's so that on January 1st, you can actually have some money for your high deductible health plan, and that's your account. So if you leave the job, you keep the money with you. Not HRA, you lose the money. HSA, you keep the money. So if you leave the job, you keep the money with you, and you can invest over time. And the intention is after 2 years or 3 years, anytime you buy a high deductible health plan, you have enough money in your HSA to cover your deductible. I've been in a high deductible health plan since 2005 myself. So my money has been funded so high that I can switch to any deductible and still have money in the bank to cover my medical expenses. And I can only use the money for medical expenses. If I use it for something else, I actually have to pay a tax penalty for it. So those were the 5 things. Reminder real quick. RAND had to be an experiment that's randomized. Why randomized? Because we wanted to see what happened to people's behaviors and the demand for healthcare, depending on how much money they pay out of pocket, right? That's 1. 2, we found that healthcare is downward sloping because as the costs went up to somebody, visit limits went down. Cost goes up, visit limits go down. But visits were elastic. Admission rates to the hospital were inelastic because you can't help go to the hospital. So when things are beyond your control, they're inelastic. No matter how much it costs, you're going to go anyway. Thirdly, spending was much higher for the free care. It was much lower for the high deductible plans. Why is that an issue? In the Republican defense, they would say if you give everyone Medicare for all and it's free healthcare, people are just going to go and you're going to have waste in the system. Too many people are going to go, right? On the Democratic side, they would say, whoa, 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 whoa. If you give low-income people and poor people a high deductible plan that they can't afford, even when they are sick, they won't go to the doctor until it's too late to go to the emergency room. And we've seen that for low-income folks, the death rates are 10% higher when they're not getting health care. That's a big deal, right? And then lastly, based on these findings, these RAND findings, health economists help create a new kind of plan, consumer-directed health plan, which combines a lot of these features together. Now, what do I see in the real world? We see companies pairing a PPO, EPO type product, a traditional health plan, with an HSA, a high deductible health plan. They offer it to the consumers, both of them, and they usually say, if I'm an employer, I'll contribute more to the HSA plan, so it's cheaper than I would to the EPO plan, so that members have to choose which one they want based on how much their employer is contributing. That's what we're seeing, but we do see popularity in the high deductible health plans. So that's a takeaway for the RAND study. I hope you could connect that study to the textbook. The textbook also has verbiage on the RAND study. This is key for your Medicare for All paper because you'll have to think about the cons of giving everyone free healthcare. What are the cons that we have to worry about, and can we afford it? Okay, so let's move on to the chapter. We are talking about the physician labor market. So we're starting our discussions on the supply side. We did the demand side last week, and now we're diving deep into the supply side, the physician labor market. So we'll talk about training for physicians, and then we'll talk about an important piece called physician agency. Now, if you recall last week, we talked about how there's barriers to entry. And we said in a perfect market, suppliers need to meet demands. And the study of economy is scarcity. When there's scarcity in the market, we try to figure out how to diffuse those resources, where those resources should go. So here, we're going to talk about why the supply side could be causing healthcare costs to be higher. So the first step is, how do you become a physician? So think about this as last week we talked about, how do you become a healthcare consumer? Easy. You literally wake up in the morning and you exist. Anyone in America can become a healthcare consumer because we can't tell when we're going to get sick. So anyone could be a healthcare consumer. On the flip side, how do you become a physician? You guys know there's years and years of training to become a physician. When it's too easy to become a consumer and too hard to become a supplier, it becomes a seller's market, which means the suppliers have the control. When it's a seller's market, what happens to price? Price goes up. So we're going to talk about some of the reasons why healthcare is expensive, specifically based around how physicians become physicians, the supplier side. So let's jump into it. Okay, medical school. Entry into medical school is competitive and selective. In the US, average 50% of applicants are accepted into at least one school. So here we talk about how the supply side is being constrained. We are constraining the amount of people that can enter the supply side of healthcare. Length of medical school varies, but in the US, people can be in college upwards of 7 years, as you guys know. And it can be super expensive. So not only is it hard to get into, and it takes a long time, it's very expensive. Three things that make the supply side constrained. It's gonna cause the supply side to always have issues of growing. And it's one of the reasons why we have physician shortage. It's hard to get in, it takes a long time, and it's very expensive. So if you were gonna think about Medicare for all, back to your paper, and you're gonna give everyone healthcare, is the supply side ready for all that demand, right? Especially the demand you're gonna get when it's free, because you saw on the previous slide how much more demand happens when the price goes down, because demand is downward sloping. Then we talk about just medical school. Now you talk about residency. On top of medical school, you still have to go into residency programs, right? You have to train to get hospital experience. So this is more on the job training. What do you think happens to healthcare costs when residents are performing healthcare? Do you think it's more efficient, or do you think there's more waste? You see this here, new residents lack experience, and when new residents arrive at a hospital, empirical evidence shows that medical errors go up. So we are adding waste and inefficiency into a supply chain that's already constrained, right? The July effect, August is killing season. So this is when you unload all of these residents in, they're doing things they never did before. Medical errors go up, not because it's bad, but it's training, right? These schools are grounds for training. That's classroom style. They're learning on the job. And so these errors go up, which means, it doesn't mean health plans deny those claims that get submitted. They still approve them, but there's a lot more waste and inefficiency in the system. So just think about the exponential growth of expenses. First, you constrain the market, you stop the umbrellas from being sold. So when people come out of the train, you can charge more for the umbrella when it's raining because it's not so simple just to get a $5 umbrella. So now you've increased the costs of the umbrella because you've taken it away. On top of it, you're adding waste into the creation of the umbrella. So now the materials cost more money, it takes longer. So it already was more expensive, and you just increase the price because of this issue of medical errors going up. There's waste and inefficiency. And then you talk about work hours. Many of you know, I read through all of your bios. A lot of folks work in hospitals, so you guys know this more than me. Many of you know that the over 60 hours a week, and I know that they implemented in 2003, limiting it, but however, doctors work way too many hours. So I'm just adding to the issue of the productivity and the lack of efficiency on the supply side. So we started out with, it's hard to get in and it's expensive if you do get in. Then we said, by the way, it's inefficient and it's wasteful because residents are learning as they go on the job. On top of it, on top of that waste, Many of the new residencies and the new doctors are tired, and they're not performing at their best capacity because of the hours that they work, and they're being paid a little bit. So these, you can see all the issues that's happening on the supply side that if we want to lower costs, we have to address. I would argue whenever you hear about the healthcare reform debate, we never talk about the supply side. We always talk about the demand side. For me as an economist, I love focusing on the supply side. I'm a little biased because I work for a health insurance company, but I love trying to find ways that we can improve this process to flood the market with supply. If you flood the market with supply, price would go down. So work hour trade-off. There's a trade-off that you'd say, hey, longer hours, there's more fatigue. However, it's less likely that there's going to be turnover between shifts. Shorter hours requires more handoffs. More handoffs give a greater chance to error. I'm going to add a discussion question on what your thoughts are, people who are clinicians, on this. From what I've seen in the data, that longer hours actually reduce chances of errors, even though people are tired and we impact their cognitive abilities because they're working longer. There's less abrasion, less turnover, less people having to reread charts, less people not knowing the story about the patient when there's longer hours. So there's a debate that's happening now that says, hey, is long work hours better or short work hours? I'll throw up on the discussion board and see what the class thinks. Okay. In the reading, you will see shorter hours leads to fewer errors. This was a randomized experiment that was done in 2004 in Harvard, and that's why we do experiments. They had two groups, 80 hours versus 60 hours, and you can see the traditional group costs more serious medical errors. So I'm curious to know your reactions to that. You could type that up as in part of the discussion points. Okay. Now, we have to talk about why are doctors paid so much money? There's actual economic reasoning around how much they get paid. And part of that reasoning has to do with all the things we just talked about in the previous slides. So when we talk about returns, we talked about it's an investment. I'm going to invest money to make money later on. So everyone talks about debt for a physician, upwards of $250,000, if not more. It's not a cost, it's an investment, because the intention is their income over the longer term will be way more than $250,000. On average, say a primary care physician can make $150,000 a year. So if they paid $250,000 to get their degree, they're making that back in 3 years, and then they still have another 60 years that they can still work, right? So in theory, that's a pretty good investment. And that's just if you're a primary care physician. And I know there's other things that you're thinking about, like insurance, and you have to think about starting a practice and those other things. But just purely on the terms of how much you're going to earn versus how much you paid to get the degree, it is a return on investment, and that's for a PCP. Imagine if you're a specialist like a anesthesiologist or an orthopedic surgeon. I mean, way more gains, longer time. So return on medical training. Unlike most occupations, return on medical training are very backloaded. And so you can see this chart here that shows when I started out, look at the AUS versus the BUS and the CUS. So this shows income vertically and time horizontally. And A shows the debt that you got into when you started to become a doctor, right? B is the amount of money you make after maybe potentially you're making a little bit of money and you're in your residency. And then after you exit your residency, you get to C and you're making tons of money. A surfer, on the other hand, you see the wavy dotted line, they don't go into debt for their craft. They buy a surfboard, maybe they get it from their grandmother for Christmas, and they start surfing and they make some money. Maybe they hit the peak of their career, so they bubble up and they come back down, and that's it. They never are forking over hundreds of thousands of dollars to become a surfer, and that's why you don't see that dip to zero income. Versus the physician who does dip below because they take on this big debt, but then they jump back up after residency, and then they jump even more farther up after they get out of school. And they end up in a hospital or they start their own practice. And so the fact that it's backloaded is saying I'm paying a lot of money up front, but I get it on the back end. And so when you think about this, in the ACA, we did debt forgiveness programs. And what we did was we asked doctors to go into areas where there was physician shortages. And if they did that, then we would forgive their debt. Now, what do you think this does to this equation? If it's free, right? The intention of that program was to say, instead of dropping down to having this big loss of income to start your career, you're going to drop to zero, because as soon as you get out of school, we're going to forgive your debt and all you have is upside. And so this chart shows the economic reason behind debt forgiveness. It allows more people to jump in, because you make the cost that they would have to pay out front to train to become a medical physician goes away. Okay, so there's a couple ways to measure this backloading method, right? And you don't have to worry about the formulas. I really want you to understand the concepts for our tests and our quizzes. So the first concept is net present value, and that's the way of calculating value of future streams of income. So think about it this way. If I'm a doctor and I'm going to be able to make $400,000 a year in 10 years, right? How much is $400,000 a year right now if I'm going to get it in 10 years? That's the net present value. So you have to think about the annual rate of return. You have to think about the interest rates, because it's kind of like a bond, right? You're given money today and you're guaranteed a certain amount of money tomorrow. That money is lower than $400,000 today. So you have to discount that $400,000 by how much it's going to grow over that 10 years. So I'm just making an example. Maybe my net present value is $200,000, because in 10 years I'm going to get to $400,000 through my rate of return. So it's trying to find out, how much do you want today versus how much do you want tomorrow? So technically, if my net present value of $400,000 was $200,000, I should only not become a doctor if I could find a job for more than $200,000. Because if I can find the job less than $200,000, it makes sense to do it today for the $400,000 later on. And that's really what the discount factor is trying to measure. It's measuring how much less an individual values future income over the present income. So it says, this is the amount of the money today for you to get what you want tomorrow, right? Now, tell me, do you want it now or do you want it later? What's your decision? And that decision is going to come from a personal person. When we talk about utility and making decisions on the margin, it's going to be a personal decision for someone to say, I'm going to work 10 years to make my $200,000 today become $400,000 tomorrow, right? That's going to be a personal decision that people make to enter in. And if you can do debt forgiveness, like we talked about in the previous slide, then more people would decide to do it, because that $200,000 goes even lower. So it's even less of a chance. So it makes even more sense to pursue the $400,000. So net present value is looking at the amount of money that you're going to get in the future, but how much is it today? And then discount factor, in that little squiggly line, is a measure of how much less an individual values future income over present income. So you saw the surfer, and I'll go back a slide. The surfer valued lower money today than bigger money tomorrow. The physician valued basically debt today for a greater future returns tomorrow. And that's what the discount factor is trying to measure. And another way of looking at the discount factor is getting to R. And we're going to talk about R. R is the discount rate. And so you can get back into the rate of return. And so you see this, it's saying the same thing, that the discount factor equals 1 divided by 1 plus R, where R is the discount rate analogous to the market interest rate. So it's like, how much money am I actually going to earn over a year? And it tells you every year how much that $200,000 is earning, so that in 10 years you can get to $400,000. What's the rate of return? And that's how we measure it. So I know you might not like formulas. Please remember this formula. It's going to be key, because on a test, I will give you then 0.9 and ask you to figure out R to 0.1. And I have slides to show you how to do it. And basically, what you want to see is people with high discount factors and low discount rates. And so basically, a very high discount factor means I'm going to earn a lot of money, but it's going to take a long time for me to get there, right? And so here's how you would solve this problem. So I'm going to start out with the formula here. So the formula here is really 0.9 equals 1 divided by 1 plus R. And now, how do I know that? They tell me in the example that theta equals 0.9, right? And then now I need to figure out how to get 0.9 and solve for R. So on the next slide, I kind of go through doing the formula. So 0.9 equals 1 divided by 1 plus R. So all I do is switch that to fractions. 0.9 is 9/10, right? So I change it to a fraction. 9/10 equals 1 over 1 plus R. Then I multiply both sides by each other. So 10 times 1 is 10, and then 9 times 1 plus R is 9 times 1 plus R. I solve it out. So that turns into 9 times 1 is 9, plus 9 times R is 9R. I subtract both sides by 10. So if I do 10 minus 10 is, subtract both sides by 9 because I'm trying to get R by itself. So I subtract 9 from 10, I get 1, and I subtract 9 from this side, and I get 1 equals 9R, and then divide both sides by 9, and so I get 1/9 equals R. If you divide 1 divided by 9, you'll get 0.11, and 0.11 equals R. And that's sort of how I solve that problem. So we would give you the discount, factor and ask you to figure out the rate of return. Now, what does that mean? Like, what does this 0.11 actually mean, right? What it means is your rate of return over time. Because I discounted the amount of money that I'm going to make long-term for today, it means my money's going to make 11% over the years until I get to my actual amount. And that is how we discuss the internal rate of return. The discount rate, which equalizes the net present value for both careers, the doctor and the surfer. And so that 0.11 shows specifically medicine. The internal rate of return in medicine is typically between 11% and 14%, which means if I decide to take a career in medicine, by the time I am done with everything, all my schooling, all my residency, and I'm ready to start my job, over that period, I would typically have 11% internal rate of return, significantly higher than market interest rates. Have you seen the interest rates on your savings account? 0.01%. A CD interest rate, maybe 2%, maybe 1%. 11%, that's better than the stock market. That's better than some hedge funds. That's a huge rate of return. That's also true for dentists and lawyers. Why is that? Dentists and lawyers seem to have the same thing. Lots of upfront costs, takes a long time to become one, and then on the back end, you get to pay a lot of money. And then internal rate of return, which is obvious, would even be higher for medical specialists like neurosurgeons, which we discussed. If you're a specialist, you're even more likely to make more money because there's less of you. So here's the issue that we have to solve in healthcare. The fact that the internal rate of return has stayed high is curious. It suggests that being a physician is highly lucrative. Duh, we know that. But why hasn't that attracted more physicians? Because this is what health economic principles are saying. If it is so lucrative, so many people should jump into that field to make that kind of money. And as more people jump in, the market gets saturated. And what happens when we increase supply? If we increase supply, prices go down because more people are supplying it. So technically, the internal rate of return for medical schools should go down because there'd be so much more people in the market. We'd saturate the market. But it hasn't happened. And why? Because medical schools are so particular about who they enter. So while who they let enter the school. So while the amount of people in medical school has remained steadily the same, it's gone up a little bit, applicants are way more than people who get in. You saw that 50% admission rate. So that 50% admission rate is keeping the supply side lower, which keeps these physician prices high. And because they have debt, they're going to seek higher prices so they can pay back that debt because they want that internal rate of return. So when you're thinking about fixing this physician shortage issue to lower healthcare costs, we have to figure out how to lower the internal rate of return on the physician side. And these are concepts we don't hear in the policy debates when we talk about healthcare reform, but we should, because the only way we're going to make it feasible so that there's more doctors in the market is that the internal rate of return is 11%, because none of us are getting 11% increases in our salary, right? In fact, healthcare costs are growing faster than wage increase. And so it's eating into our salary, which means we're getting into more debt. So all of this explained by the barriers to entry, and we talked about this in the first class, is barriers to entry to becoming a doctor. In the 19th century, becoming a doctor was simple. Anyone can do it. There wasn't training. But American Medical Association came about and they made it prerequisites for medical school. They made schools 4 years. They made it a license that you have to practice. And it did help shut down low quality medical schools. This was the Flexner report. But the result ended up being less medical schools, less med students, higher internal rate of return, shortage in the market. Consumers, there's no barrier of entry to become a consumer of healthcare. I get the flu, I'm a consumer of healthcare. I can't help it. The actual suppliers of healthcare, the physicians, huge barrier of entries that we just went through, and you could name them all. There's even more barriers of entry. They cap the medical class size. The argument is if you can't have too many people because the people can't learn. So we cap it, which means even less people can get in. You need a license to practice on their own. We have physician assistants. They're entering the market at a lower price, right? Nurse practitioners can issue prescriptions. They're entering the market at a lower price. They have a lower internal rate of return because the costs aren't as high to become a nurse and to become a physician assistant. However, they don't have the same spectrum of services that a doctor has. And in most cases, the doctor has to be present, at least in New York, for the physician or be the point person for the physician assistant to actually operate. And so this includes and increases the issues around the shortage on the physician side. So the trade-offs, because of the barriers of entry, consumers have to pay above the competitive rates. This is key. When consumers pay above competitive rates, physicians earn monopoly rents. Remember in the first class we talked about monopolies? That's when it feels like there's one supplier. Well, this is interesting. There's many suppliers. There's lots of doctors. However, because the consumers are paying above competitive price, it feels like it's a monopoly. So it's called a monopoly rent, because the consumers are paying above the market average because of this internal rate of return of 11%, because of the shortage in the physician market. Wages above the competitive price due to artificial constraints to the market. Monopoly rents, very important point. If you're going to start Medicare for all, you gotta fix this. Because think about what we're saying. We're gonna reduce how much we pay doctors in Medicare for all as you read through it, yet we're going to increase demand because more people will have it and it'll be free of charge. Yet, the competitive price of the nature, we have constraints. So we're going to send more consumers with higher demand to fewer suppliers. You're going to increase costs exponentially. Barriers to entry ensure that physicians are qualified. So that's the good point. Because we have this, it means that healthcare should be better. Now, if you think about our first class, we talked about how even though we spend a lot of money, we don't get the quality. So despite these barriers to entry, we're not getting the quality that we're paying for. That's an issue as well. Okay, the last concept for this week is the physician agent. And this has to deal with one of the tenets of health economy, which a free flow of information between the consumer and the physician, right? We said when you buy a car, if the consumer knows as much as the car dealer, then the consumer wins out because they can be able to check how much the price costs of the car and they'll be able to buy a price that they want, and you get equilibrium where the supplier is selling the car at a price that they want and the consumer is buying the car at a price that they want, and all the information is there so they know who's getting a deal, right? That's what's supposed to happen. In the medical field, that doesn't happen. In the health economy, that doesn't happen. And because of that, we call it the physician agents. So physicians as agents, and think of it almost like basketball, football, right? Players have agents, someone's acting on their behalf. It's a similar concept in this realm. Patients trust physicians to act as perfect agents to their health, just like a basketball player feels like a sports agent will act on their behalf because the better contract that the player gets, the more money the agent gets, right? So doctors' foremost concern should be patients' well-being. As you know, Hippocratic oath, do no harm, and they're not out for their own financial status or reputation. Let's pause. So we talked about in a market, people want to buy goods and services and they want to maximize their dollars in a perfect market. So whether physicians want to or not, there are economic forces that cause physicians to get into the business to make money. Think about it. they're putting lots of debt in the forefront because their profits are backloaded. So they want to make that money back. So the fact that a physician as an agent wouldn't go after their own financial status reputation is hard to believe in a health economy. If a health economy has buyers and sellers and both parties' objective is to get the best price, the consumer wants the cheapest price, the seller wants the highest price. It's law of demand and supply, right? So the idea that physicians are perfect agents just isn't the case. They might be imperfect agents, but they're not perfect agents. So the question here, are doctors always perfect agents for their patients? I'm sure you can think of examples of where doctors are not. I will put a discussion question on the board around that as well. You can either answer the first one or the second one. You don't have to answer both. It's up to you, but it'll be a good, I think, debate on the discussion board. So what happens when the physician-agent relationship exists? What happens is information is asymmetric. They call it information asymmetry between a doctor and patient. The patient cannot assess whether an extra test or procedure ordered by the doctor is necessary. So physician-induced demand is caused by the patient trusting the physician and then the physician having more information than the patient. So the patient takes all the decisions that the physician makes because they trust them, right? And now if the physician has an economic interest in having more tests, then the patient is likely to have induced demand, meaning the demand for healthcare didn't come from the consumer. The demand from healthcare came from the physician. And the reason why the consumer listened to the physician is because of the physician agency. So financial incentives for doctors to prescribe more services are needed. There's actually empirical evidence in the textbook, in your readings, that when reimbursement rates, various procedures change, doctors' prescription practices also change. So the simplest example is this physician, this health plan pays me $100 a visit. This health plan pays me $300 a visit. If two people are booking appointments, who am I going to do first? Now, in a perfect world, it wouldn't matter, first come, first serve, but that's not how it operates. There's certain practices, I'm sure, that what the type of insurance weighs into the decision making. And so physician-induced demand is consumer demand that's even further increased because of the fact that the consumer doesn't know as much as the doctor. So they're dependent on the knowledge of the doctor for them to make a decision. How do we reverse physician-induced demand? Because this is another reason healthcare costs are so high. A lot of our consumers are listening to the physicians, and there's no way that we have today to check on physicians to make sure they're prescribing the right things. One of the things is a cost registry. Just like you have Carfax, or just like you have the Blue Book, where you can look up prices for cars anywhere, we're trying to get to the same thing in healthcare, where you can find out, I need a hip surgery. How much is it at hospital special surgery? How much is it at Mount Sinai? How much is it at Northwell? Include the anesthesiologist, include the assistant surgeon, include the follow-up visits back to the orthopedic surgeon or whoever's doing the surgery, right? That's what we need to get to, so that you can actually see as much transparency in the cost as you do when you buy a car. We're not there yet. And there's reasons why we're not there yet, because if that transparency happened, pricing would dramatically be reduced. Now, another issue, which I'm sure you guys have brought up, is defensive medicine. And this is doctors fearful of lawsuits. So because of that, if you're fearful of lawsuits, you're going to overutilize, you're going to overtest, and you're going to worry about malpractice. And this happens because you're trying to defend yourself from the accusation that you didn't do what you're supposed to do. So if you know the person only should get one test, but they might sue if something goes wrong, then you're going to order 7 tests. And that extra ordering is waste and inefficiency in the system. And because you have the physician agency, the consumer is going to do it, right? And that's why health plans send out EOBs, explanation of benefits, because we want the consumers to see, here's all the tests your doctor ordered. Do you need all these? Did the doctor tell you you're getting all of these? Because we want to make sure we can protect against physician-induced demand and defensive medicine. You can see MedLL in 2010 estimates that medical liability system in the U.S. costs $55.6 billion annually. Imagine if we could take this cost out of the system. How do we reduce costs? Now, think of it this way. Medicare for all. We're going to add demand. not just because more people will have insurance, but they're going to ask for more services because the cost goes lower. Double dip. Do you think defensive medicine and physician-induced demand is going to go up or go down? How do we defend against it, right? Racial discrimination. So discrimination is an interesting concept here. There's types of discrimination. Taste-based discrimination, which is preferential treatment for certain groups, and then the statistical discrimination, which is based on stereotypes for behavior tendencies. Believe it or not, discrimination can be efficient or inefficient. And there's some discrimination that harms patients, but others that benefit them. So what does that mean, right? Here's an example. There was a study, and I'll post it online. I'll remember to post it online. You can read it if you'd like. It's not homework, but if you're interested. There's a study that shows when Black men in Oakland see Black doctors, they actually listen to their doctor more often. They're more truthful, and they get healthier outcomes, right? That's what we would call efficient discrimination. And the reason being is they showed in the study that the physicians actually gave extra effort. So what ended up happening is there was more trust faster and sooner between the Black patients. And then on the Black provider side, there was actually extra effort, inherent extra effort to sit down with the patient, talk to them, and try to explain things in more detail with the Black patients. Now, this didn't mean that they were giving subpar effort. Everyone was at 100%, but for some reason, when the physician race was similar, certain doctors gave 110%. Clinicians, I'm curious on your thoughts on efficient versus inefficient discrimination. And then obviously there's inefficient discrimination, which is just basically wrought with when I see somebody, I have a negative view of them, of their biology, of their behavioral tendencies, and so I just render care differently. And this can be conscious or unconscious, and we always have to take out bias in the system because bias hurts us. The other discrimination we can talk about too is, which we talked about, I think in the last class I mentioned this, is where you do residency versus where you practice. If a doctor that grew up in Nebraska, did the residency in Nebraska, but ends up practicing in the Bronx, they are going to treat patients in a similar manner as they know that they learned in Nebraska, as opposed to the Bronx doctor who saw a wide range of ethnicities, who saw a wide range of different diversities, and who learned about healthcare disparities amongst cultures and was able to learn how to treat patients differently based on where they're coming from in their communities and things like that. That's an unconscious bias that a doctor would have. It's not intentional. It's just that they haven't had exposure to that those culture and those groups. Efficient discrimination, an example, is there are physicians who treat females, Asian women in Chinatown for cancer screenings because they have learned that many of these females that are low income potentially work in restaurants in Chinatown are in front of woks cooking food, and they're getting this gas into their lungs. If you treated them, you would say, do you smoke? They'd say they don't smoke. So there would be no reason for you to ever do a lung cancer screening. But because of this efficient discrimination, which is based on behaviors and based on traits that you've learned through cultural immersion with this population, you've learned that, hey, we've detected patients many times that ended up having no symptoms of lung cancer, identifying that they do not smoke, and then not realizing that they work in a restaurant and they're around all these fumes when they're in front of the woks cooking, and they end up with stage 3, stage 4 lung cancer because it was never detected. Efficient discrimination would be, oh, you work in a restaurant? Oh, you're of this ethnicity? Oh, you live in this neighborhood? Just in case, let me do this test. Efficient discrimination versus inefficient discrimination, which is purposely, if you're if a physician is against LGBTQ, for example, rights, not seeing those patients, which is inefficient discrimination. But discrimination is a big deal because we talked about the amount of diversity that's in America. We have to make sure our supply side can handle the diversity in America. It doesn't mean they have to look alike, be alike. They have to be aware of it. They have to be educated. They have to have cultural competence for the patients that they're going to see. That's more of an issue here than in other countries that have single payer, where they don't have the rate of diversity that we have. So it's something that we do have to think about, and especially with Medicare for All. The people who are uninsured have a higher probability and higher proportion to be diverse communities. So now you're adding these uninsured diverse populations into a medical system that is not that diverse, right? And so we have to think about that, and that's things that you should attack in your paper. So I'm not going to go through this, but it talks about evidence of discrimination, physicians less likely to recommend standards of treatment if the patient was Black, and the differences between efficient and inefficient discrimination. Okay, so this is an example of efficient discrimination. I actually talked through these slides before I went through them. Okay, so in conclusion, wrapping up week 2. This is on the physician side. Physician supply is highly regulated. The fact that it's regulated means there's less of them. It leads to shortage of doctors. It's hard for other healthcare providers to fill the void, so when there's less doctors, price goes up. Investment returns to being a doctor and specializing is very high because there's less of them, so they make more money. Monopoly rents, don't forget monopoly rents. Consumers of healthcare who can't choose to be consumers are paying too high prices because of this physician shortage. We have to fix it. Lastly, physicians are not always perfect agents of care. There's overutilization, physician-induced demand, defensive medicine, and racial discrimination. So this concludes the physician side of the supply side. Next week, we will tackle the hospital side. I will answer your homeworks by this weekend and your case studies. And if you have any questions, feel free to email me, and I will post the 2 discussion points, the two discussion questions tonight.